Yeah, good afternoon, everyone. I request Dr. Purohit to come forward and present his talk, Aware of Problems, Not All Nightmares. Dr. Purohit, you are live. You can go ahead. Starts.
Thank you, Kantilal, for this opportunity to talk on one of the most important thing when we do a CTO PCI, that is being aware about the complications so that you don't land up in any nightmares. So anybody who thinks of or tries to do any PCI, and especially CTO PCIs, we must be aware about some limitations and some complications so that we are prepared for all those eventualities so that the patient doesn't have any issue. Next. So we all know about it. CTO means if you have a totally occluded artery, TME 0 or TME 1 for more than 3 months, and in our day-to-day practice, almost 30 to 40% of PCIs are having CTOs. Next. So if you, I always believe in history and I always try to show that. So the first description of CTO was way back in 40s, and the importance of collateral circulation in CTO we understood since 1960s. And the first successful PCI for a totally occluded artery was published way back in 1984. And the first retrograde wiring was performed, but in fact it was done through a vein graft, and that was done in 1990. But the pioneering moment came when Dr. Kato, who is still considered the father of retrograde PCI, he published his first data in 2005, and since then he has been involved in a lot of development with of the wires and the devices to improve the success rate of PCI. So initially in the 80s and 90s, the success rate was around 50 to 70%. Now with this development of this retrograde approach, we have reached more than 80%, and in some of the high volume operators, it has reached almost more than 90%. Next slide. So the benefits, we all know, it helps in improving symptoms. We have improvement in LV function and possibility of mortality reduction. And when we have a CTO, many times if you are not confident, we send the patient for surgery. But if you are a confident operator, you can avoid the CABG for this kind of patient. Next. So what is important is when you attempt this, you should be aware about the problem so that you can avoid nightmares. That's the motto of this talk. So with the development of techniques, the devices to treat CTOs, it has reduced the rate of complication. And now we have the major complication like death, CABG or a stroke rate as low as 0.5%. So which is quite good. And the operator should always be aware of complication, which are more common, like both coronary as well as non-coronary complication. You should be aware. So you can stop the procedure before those complications happen. And most important to reduce complication is to be aware about the properties of the wire or the support devices which you are using, so that you know that this device can lead to this complication, so that when you are doing the procedure, you are always looking at the complication and always trying to prevent it from happening. Next. So this is how the algorithm is. The CTO PCI related complication, whether it is cardiac, extracardiac. In extracardiac, we have the most important radiation injuries, the vascular complication, and the contrast nephropathy. And in terms of cardiac complication, we can divide them into coronary and non-coronary. Non-coronary is basically aorto-ostial dissections, and coronary complications are either acute vessel closure leading to because of thrombosis or dissection, or we can have a side branch occlusion, or there may be entrapment of the equipment like the wire or the devices or the rotablator burr, etc. And in coronary, we can have perforations which can lead to tamponade. Perforation can be of main vessel or the target vessel, or it can be of the collateral vessels. Next slide. So we'll go briefly to some of these complications. Next slide, please. So first and foremost, next slide. First and foremost, we must understand the most dreaded complication is coronary perforation. Next. And we all know this, the Ellis classification of the perforation, which can guide us how do we treat this patient. Next slide. So observed complication rate with a non-CTO PCI is almost less than 1%. That is almost 0.2 to 0.3. But in a CTO PCI, because of the use of very heavy wires and the channels and septals, which are very fragile and thin, the complication is seen in almost 10 to 12%. But good thing is most of these complications are self-limited. And overall person developing a truly a tamponade is very, very rare. It is only 10% of all the perforations which we see. If we are seeing 100 perforation, then only 10% will have a true tamponade in this patient requiring a major intervention. Most of them can be managed without much intervention. And the rates of perforation and tamponade are especially high if you are going with a retrograde approach, and especially if it is a failed PCI compared to the ones which are successful PCI. And next slide, please. But the incidence of tamponade, whether it is antegrade approach or retrograde approach, the incidence of tamponade is same in both. And as I said, the perforation can be in main target vessel, either at the CTO site or inside the CTO, or distal to it, that is the distal target vessel, or it may be in the septal collaterals or epicardial collaterals. Now, the most important thing is how do we prevent it? So the prevention is, you should be careful about your guide wire, and when you are taking the guide wire in, you should know the curves, how the vessels are taking, which you can always visualize with a retrograde injection, or you might be having a prior CT to tell us, okay, this is the channel of the CTO, this is how the CTO behaves. And you can always keep a eye on the wire movement which is happening at the distal tip. Try to avoid the wire in the distalmost small branches. And if at all you are thinking that your wire is in true or false lumen, you can always give a retrograde injection to check whether the wire is in true lumen or false lumen. Suppose there is a big perforation and the patient is in hemodynamic compromise. We all know how to handle complication, but this one thing I will tell you, which is called a ping pong technique, where you occlude the vessel proximally with the help of a balloon. And when the balloon is still occluding the vessel, take one more guiding catheter and take another wire on that guiding catheter and keep that wire. When this second guiding catheter comes close to the ostium of the vessel, then slowly remove this first guiding catheter, because the balloon is still occluding it. So you can always remove that guiding and take the second guiding, hooking in the ostium, and then take the wire in. And at that point, you deflate the balloon, quickly cross the wire and take your cover stand and deploy it, so that you don't allow too much of hemodynamic instability in this patient. Because many a time these perforation happen, they are a massive perforation if you have done a balloon dilatation or if you have done a stent deployment falsely in a vessel, and which will give rise to a torrential blood flow into the pericardium, leading to rapid hemodynamic compromise. So to avoid that, we recommend this ping pong technique. If the patient is deteriorating rapidly, just occlude it, take one more guiding, take one more wire, and rapidly deflate, put the wire and put the cover stent there. So this is how you can avoid hemodynamic instability. Sometimes if there is a total occlusion and we see that the distal vessel is occluded and we have still not dilated the proximal vessels, or if it is in the very, very small branch, we can use the microcatheter to suck the blood out, and that negative suction will collapse the vessel and it will lead to hemostasis. And many a times we have seen this occluding the perforation and sealing it completely. So in that case, in the small channels, like distalmost small channels, this technique really helps, and almost 50 to 60% of time you may not need any coil or anything of that sort. Next slide. So in the septal channels, the tamponade rarely happens because it will be in the wall of the myocardium, the septum, and it can give rise to hematoma, and very rarely it opens into the pericardium. And most of the time it will be either contained there or it may open into the cavity without giving any issues. And extremely rarely this septal hematomas can give rise to a heart block or a VT or a septal wall rupture or LVOT obstruction, which may need a surgery. Otherwise, most of the time the septal collateral perforations are self-limiting and nothing to be done for them. Of course, they can give rise to some pain, which you need to accept and give some painkiller. But the most dreaded are epicardial. The most important thing is epicardial channel approach should be taken only by the experienced operators, because these vessels are corkscrew shaped. So it is very difficult to negotiate. And when you are doing a epicardial channel surfing, you should not take taper tip wires like a filter XTR or a filter XTA. Even if you are taking them, we generally recommend to make a very, very small J, almost like a J, like a hockey stick you have to reverse it and then slowly manipulate. Generally, we tell them not to take this tapered wire, and the wire to be preferred is the SUO3 wire with a small curve at the tip. And with that, just gentle movement, the SUO3 wire can track this epicardial channel. But I will suggest these epicardial channel should be addressed only by an experienced operator. And if at all there is a wire which is going and you get stuck, try to avoid balloon dilating the epicardial channels, because invariably they lead to perforation. And suppose there is a perforation also, the most important thing is try to aspirate there and give a negative suction so that the vessel collapses and the perforation can be sealed. Otherwise, if it is still leaking, it will invariably lead to tamponade. So we have to occlude it from both the sides. From the antegrade as well as retrograde side, we need to occlude it so that there is no flow into the collateral channel and tamponade can be avoided in them. So these are some of the tricks and tips which you need to do if you are handling a epicardial channel perforation. Next slide. So this is the algorithm. We all know about it. Inflate the balloon, give IV fluid, vasopressure, pericardiocentesis, notify the surgeon, and if the extraversion is still there, then you have to treat the cause. If it is a large vessel perforation, put a covered stent or prolonged balloon inflation, or you can do a dissection technique where you can just like a star technique of the Colombo, you can dissect the proximal part, go distally and inflate the stent there so that the flap will close the perforation. But that is very, very risky, and it requires a lot of expertise to use the dissection technique. In distal vessel perforation, as I said, you can do a suction and give a negative so that you can collapse the vessel and close it. Otherwise, if it is not happening, then you can use patient's own thrombus or patient's own fat, which can be passed through the microcatheter, or you can give coils, and if required, if it is not helping, then you can put a cover stent on the artery from which this collateral is arising. So that part you can cover so that the origin of this collateral can be closed by the cover stent. If it is still persisting, think of reversing the anticoagulation and send the patient for surgery. Next. One thing I'll tell you is there is a common myth that post-CABG patient don't get tamponades, but yes, they can still develop it, and which can be due to focal compression of the right atrium or the left atrium. And in that case, you have to go with a very, very experienced pericardiocentesis, and many a time they'll require surgery again. Next step. So one thing I'll tell you is, the moment you see a perforation and you are thinking of doing something, the first thing you should do is inform your cardiac surgeon and tell them to be prepared, because you are not supposed to waste any time. So the surgeons are preparing themselves. In the meantime, you are handling it. And if things are okay, nothing to worry. If things are going wrong, the surgeons are already ready and you can save a lot of time in that. Next slide. So I'll give you one example. 55-year-old gentleman, we did this procedure recently, RCA CTO distal segment. Next. Next. Now you can see here, this is the distal part of the RCA is completely occluded. We took initially took a filter XTA with the help of a microcatheter. Next slide. It was not going, so we escalated it to a Gaia wire. You can see the wire has gone, but I think probably it went outside. So we tried multiple times, but we could not go into the true vessel. And we checked it. You can see in the other side, there is truly a dissection, and we are not in the true lumen. So we decided to go retrograde here. So this is one thing where you can see all the things which I have till now described. So dissection you can see there. Next slide. And you can see we wanted to go retrograde. There was a beautiful epicardial collateral, and also you can see distal LAD has got a good collateral, but just at the beginning of the collateral, you can see there is almost a J-shaped curve, which is like a loop there, and then it is connecting distally. So we took a SUO wire to cross this loop. Next slide. You can see the J shape which is there in the first next. We are trying to cross it, and you can see on the other picture how it has taken a loop. So with the loop and the SUO wire, we were able to cross it. Next slide. Now what happens is probably something happened and there was a perforation. You can see the perf in the both the angles, in the iliocranial as well as the PA cranial view. You can see the perf there. But luckily, this perforation is happening in a cavity, so nothing is happening. So the patient was stable, nothing was happening. So we decided we are not going to do this. So we stopped the procedure there, and we wanted to come back again sitting in the next day. Next slide. So we waited. And in the next slide, we wanted to go with this epicardial collateral. You can see in the extreme end through the diagonal it is coming, but there is a lot of tortuosity there. So again, we took a suo wire and created almost a J bend, small J bend, and tried to cross. Next. And you can see we are trying to cross it, and in the outer segment you can see there is a perf again in the epicardial collateral. Now you can see that it is a very small branch and the size is very low. So what we did is we aspirated it for some time, and with the help of a wire we crossed it, and we thought that probably the microcatheter is going to act like a balloon tamponade. So the microcatheter, when it crossed it, we found that it is occluding the vessel, and there was no leak. So we just continued with our procedure. Next slide. And you can see here we crossed it, and we are seeing the retrograde wire trapping in the RCA, and we deployed a stent. And after deploying the stent, next slide, we checked the collateral. There was no more perforation. Probably the microcatheter had acted like a tamponade and sealed the perforation, and there was no more perforation. There was no hemodynamic instability, and patient was sent home within 2 days of time. Next slide. Another important is dissections, and the dissection can happen due to the guide catheter or guide extension or due to guide wire. Now, this is mainly because of we use of large bore guiding catheter like 7 French or 8 French, which are used basically to allow us to use multiple devices like microcatheter or IVUS, and many times we use all of them together, and multiple wires are taken. So these large bore catheters, they provide a lot of support, but they are also coming with a higher chance of dissection at the ostium. And many times when we have already crossed the channel, when we try to remove the wire or try to manipulate the microcatheter, the guiding just gets sucked in, or the extension catheter will get sucked in and cause dissection. So the most important thing to prevent is maintain the guide wire and do a quick stenting to cover the dissection flap, and make sure there is a full expansion and coverage of the entry point to prevent further dissection. And if the guide wire is lost and the flow limitation happens, then suppose there is a dissection at the ostium and we have lost the guide wire, then what we have to do is we have to take another catheter which has a different shape, because the same catheter will always hit the dissection sites again and again. So take another catheter which, like if you have taken a JR, then maybe you can take a Ampla's catheter which will be hooking upside. JR will be hitting the lower part of the vessel. So based on your anatomy, how the catheter was sitting, choose another catheter and try to cross it with another wire and then try to seal it off. And when there is a dissection at the ostium, try to avoid hooking the ostium and giving an injection, because the moment you do that, you are going to expand the flap more lower down. So what we should do is you should keep the guiding close to the ostium and give the injection in the sinus rather than hooking it and giving an injection in the guiding. And most common wire which I take for recrossing or all this thing is always a Xion blue or a Swan block for rewiring. And if the stable retrograde wiring, if the patient is stable, you can always come retrogradely also and cross it and put a stent there also. So these are some of the ways you can control this dissection which are happening at the ostial junction. Next. Now this is a guide wire induced dissection. What do we do? And this is mainly because of use of heavy wire, single or parallel wire. And when there is a guide wire related dissection, and try to avoid giving antegrade contrast injection again and again to check where you are going, because you are going to increase the dissection flap. And always try to give an injection through the collateral in the retrograde thing. If the guide wire entry from dissected false lumen to true lumen is difficult, use a IVUS guided re-entering, and generally prolonged balloon inflation with adequate size balloon will calm down most of the dissecting flaps. And sometimes the dissection can cause acute thrombosis. So we must maintain adequate anticoagulation. And if the medical therapy and prolonged ballooning does not settle the things, then we have to think of putting a stent there. If there is a dissection by balloon dilatation or stenting, additional stenting to cover the proximal or distal side is always recommended. And when the residual stenosing after the ballooning, if still it is more than 50%, you must think of it. And especially any dissection happening in the left main area, you must always have a low threshold of putting a stent there, because if any thrombosis happens, you're gone. Next slide. This is a 40-year-old RCA ISR which is occluded, and the ISR was attempted in another hospital. They failed it. The patient came to us. Next slide. And you can say we have taken a knuckle wire, try to cross it, because the first time it has failed. So probably what happened is they said we crossed the wire, but balloon could not cross. So probably I thought that they might have gone through the side, through the struts. So instead of doing that, because it's a total occlusion, I created a knuckle to enter into. And next slide. And after entering a little bit, I again made it, removed the knuckle and crossed it. But I went into the PDA here. But when I checked the shot, I found that I am in a PDA, which is a very small vessel, whereas the PLB supposed to be a bigger vessel. So I withdrew the microcatheter a little bit and gave an injection again. Next slide. And you can see here, when I gave the injection, you can see a huge dissecting flap you can see in the PLV. So I was not sure whether I should proceed or not proceed. And I was also not sure whether it is truly a dissecting flap or not, because I have never seen that just with a simple microcatheter related injection, creating such a huge dissection, which is involving all the branches. So I was in a dilemma whether it is truly a dissection or it is something else. So next slide. So I crossed with a wire. I took a very soft wire and crossed distally and gave an injection at the distalmost part of the vessel. And I realized that it is a true lumen. So I came back and tried to open all the branches which were there. Next slide, please. With the help of a gentle ballooning, I opened all the branches and then I put one more stent. And now you can see that was actually not a true dissection. So many times this dilemma will come to us, and you need to trust your judgment and go ahead and decide what is the best for the patient, because there is no guideline related thing to tell you whether how do we handle these things. So you need to go ahead and go ahead and do the best for the patient. And you can see that was not a true dissection. It was because of low flow. Probably the the blood flow was not enough, and it was just going only in the main vessel and not occluding the not going into the smaller branches. But final result was excellent, and patient was sent home. Next slide. This is something which is also very important in CTO PCI, stent entrapment or stent loss, which of course not very common, but can happen in 2 to 3%. And especially it happens when you are trying to push the stent when the bed is not properly prepared, especially in dense, hard, calcified and angulated lesions. When you try to forcefully push it, and many times rather than pushing, when you try to withdraw them, many times the stents get deformed at the ostium of the guiding, and then they just the stent just comes out of the balloon and it gets dislodged there. Next slide. So you need to be very careful. The techniques which are mentioned are, if the guide wire is already there, you can take a smaller balloon, deflate it distally and pull the whole assembly, or you can cross multiple wires and keep rotating them so that they form a loop-like thing and they hold the stent there and pull it back. Or many a times, if you can use a snare, because already the wire is there, so you can push the wire, the snare over that wire, and you can try to hold it. And many a times, if the stent is in a proper place, you can push a small balloon and you can deploy it there itself and go ahead with another stent or another wire, crossing it and completing the procedure. Next slide. Suppose the wire is lost. If you have lost the wire, the stent is out of the wire, then you can take one more wire, knowing very well that this wire may not cross it. So go from the side and try to plaster the stent on the side by using another stent and pushing it there. Next slide, please. Now, finally, if the approaches doesn't help, you can always take a surgeon's opinion. Balloon catheter break and entrapment, it is also quite common, because many times we use O balloons and O catheters, which gets broken from the and then how do we assess it? You will see that the balloon which is having two markers will be there in the coronary, whereas the other part has come out. So you can check what is the length which has come out to assess how much of the free balloon with its shaft is there inside the coronaries and in the aorta. So in that case, you can use a snare or you can use a bioptome to hold it and pull it back. If it doesn't work out and you're not sure where you are holding, then another good thing is you can use a balloon trapping method, where you can take a bigger size balloon. Like if it's a 6 millimeter, 6 French, you take a 2.5. If it is a 7 French, take a 3 millimeter. But important thing is you should take a long balloon. For wire exchange, we take around 10 or 12 millimeter. For here, I will recommend take at least a 23 or a 28 millimeter balloon, long balloon, inflate it at 14 or 16, and then try to pull out the whole assembly, rather than trying to do any other maneuver. So this balloon trapping is a good technique of removing the stuck wire as well as the stuck catheters, if at all anything is stuck in the coronaries. Next slide. And after removing the whole system, you can do it. This is how you crush the stent. Next slide. So this is about guide wire entrapment or fracture, which is quite common if you are not careful. Especially we used to see this with Gaia set of wire, the first generation of Gaia wires which are there. Nowadays they have come up with Gaia Next, which with the extend technology. There this is not happening, but the first Gaia has multiple coils. So when you try to remove it, the coils just uncoils and the whole wire system comes out. So be careful when you are using Gaia wire, and try not to rotate too much, because if you try to rotate it, the Gaia wire will get stuck in some calcium or somewhere and it may not come out. So in that case, when you try to pull, the whole spring coil will just stretch out and it will come out and will break. So this is quite common with them. So when it happens, the technique to remove is either, again, as I said, balloon trapping, or use a snare, or you can use with the help of a forceps, or if it has broken, then what you can do is you can plaster the wire on the wall of the coronaries by using a stent, and any wire which is hanging in the aorta is not going to cause any trouble because it's a very high flow situation. So what you can do is you can put a stent in the left main ostium, so that up to the ostium there is no free wire in the coronary, and after that you need not worry, just continue with the antiplatelet. Next slide. So this is all the techniques which have been mentioned to remove the wire. Next slide. Another thing which we saw today also, it is called donor artery thrombosis. The most important thing to prevent is keep checking the ACT every hourly and try to maintain a ACT of more than 350. And keep flushing your retrograde guiding catheter so that no thrombus is found, because many times we push the microcatheter and try to go to the collateral and we forget it, because we are so engaged in manipulating through the microcatheter, we keep forgetting the flushing the catheter. So the blood which is there may form a clot. So keep flushing the retrograde catheter all the time so that you don't allow any blood to stay and form a clot. If there is a previously implanted stent, try to avoid crossing through the stent strut and accessing the channels. Next slide. And if you feel that there is a thrombus which is forming, the most important thing is remove the retrograde system, because nowadays, even if the wire is crossed, you can always push your guiding through this coronary wire and take it right up to the ostium. And for that, the technique, as I said, when you are trying to access already hooked wire, you don't want to remove that O1 for wire. We are always worried that the guiding may not track over this thin wire. But what you have to do is you can take a support wire with a Terumo wire, and along with the Terumo wire, along with the coronary wire, you can take it. You don't have to remove the original wire, which is already crossed with a lot of difficulty. And the moment you reach the ostium, you remove your Terumo wire and you can hook the guiding with that. So that's a standard technique describe how to push your guiding catheter over a coronary wire if you are suspecting any thrombus. And so you remove the whole system, take again one more system. If required, give GP2B3 inhibitor, use aspiration catheter like what was done in today's case, and try to see if it happened because of any dissection. If it is there, then you put a stent there. If there is a distal slow flow, you can always give nicorandil diltiazem in this patient. Next slide. Another very important thing for a CTO PCI is when to stop. Two important things which help you stop the procedure is radiation injury and contrast nephropathy. The moment you see that in the fluoro itself, you will keep getting how much exposure has happened. The moment you have more than 10 gray with more than 50 minutes of fluoro time, about the procedure. And you keep telling your technician to keep alerting you that every 2 gray exposure, he should keep telling you, sir, 2 gray, 4 gray, 6 gray. The moment it is 10 gray or 50 minutes of fluoro time, try to remove it. And try to use 7.5 frame per second rather than 15 frames per second. Try to avoid cines, because there is no need to take cines. Your fluoro can be saved, and use 7.5 frame per second rather than 15 frame per second. Next slide. And what is important is the patient should be kept away from the source of the radiation. This is how you measure the grays. Next slide. Next. And this is what happens if how much gray you have exposed and what are the complications you can have. You can go up to skin cancer, late dermal necrosis, all this thing can happen. So once you have done it, you should call your patient back, and every 2 to 4 weeks, you should keep checking the skin, whether any problem is happening or not. Next slide. Next slide. Contrast nephropathy, we all know what it means. The common predictors are advanced age, anemia, diabetic, heart failure, hypotension, pre-existing kidney disease, or if large volume of contrast is used. Next slide. So the most important thing to prevent is saline hydrate the patient with at least 1 ml per kg per hour for the 24 hours. And it should start 12 hours before the procedure and should continue for 12 hours after the procedure. And the target is patient should be passing at least 150 ml of urine per hour. Then only you feel that yes, adequate hydration is being given to this patient. And another important thing is try to avoid too much of contrast injection when you are manipulating the wire. Use anatomical landmarks like a calcification which is there, or use a IVUS to minimize your contrast load. What is the maximum contrast which can be given in patients to avoid it is coming by the formula 5 ml into weight divided by baseline creatinine. That should be your maximum allowable contrast dose. Or another formula is 3.7 for the contrast volume to creatinine clearance. So a ratio of less than 3.7 for contrast volume by creatinine clearance. That is again another criteria you can use to decide, okay, this much contrast I'm going to give, other than if it crosses more, I'm going to stop it. Next slide. So these are the complication kit you should always have when you are attempting any CTO PCI: pericardiocentesis kit, covered stents, embolizations, embolization tool like coils, fat, thrombin, equipment retrieval like snares, micro snares, and support devices like ECMO or Impella. And you must know how to access your vascular complication or groin compilation. Next slide. So the take-home message from my talk is CTO PCI is to be attempted by experienced operator in experience center with sufficient backup. Tools to handle like snares, cover stent, gel foam, guide extension catheter, pericardiocentesis set, etc. should be there. As the procedure involves various guide wires and support devices, you must know what they are and what is their properties. Awareness of radiation hazard as well as contrast nephropathy should be there. And baseline creatinine EGFR value should be known so that you don't cross the maximum allowable contrast load in this patient. Awareness and alertness can lead to preventing complication or early identifying of complications so that you can give them treatment. Knowledge of problems and their early prompt treatment can avoid many nightmares of CTO PCI. And most important is always stay calm, composed during complication and never panic. And keep your surgeon happy when you are trying to do any CTO PCI so that he's on the loop for any complication. He can always come for your help. Thank you very much.